Just heard Jim's computer go on. So, okay, I'm going to begin. Welcome to the Monte Vista Grove Homes Weekly Convocation, underwritten by our resident executive council led by Jeannie Cobb. We're grateful to our CEO, Deborah Herbert, for her ongoing support, to Edgar Curiel and his team for connecting us with you each week, and to the Convocation Committee led by Terry McGonigal. And thanks to each of you who attend each week, for you are the reason we gratefully meet. Let's begin this afternoon with a scripture reading from Matthew 25, verses 34 through 35, and it's from the RSV. Come, O blessed of my God, inherit the kingdom prepared for you from the foundation of the world. For I was hungry, and you gave me food. I was thirsty, and you gave me drink. I was a stranger, and you welcomed me. I was naked, and you clothed me. I was sick, and you visited me. I was in prison, and you came to me. Thanks be to God for his word to his faithful people. For our prayer today, I'm using the words from one of the moving hymns, new to me until Rebecca Thompson shared it with us at Tuesday's Lenten Hymn Meditations from the Glory to God hymnal. It's number 796, titled, We Come to You for Healing, Lord. And I'm going to be reading verses 3 and 4. You touch us through physicians' skills, through nurses' gifts of care, and through the love of faithful friends who lift our lives in prayer. Through nights of pain and wakefulness, through days when strength runs low, grant us your gift of patience, Lord, your calming peace to know. Amen. In the mid-70s, our friend Donald Ham was making films for the Franciscans. One film was titled The Near Edge. There's a line of dialogue in that film that has played in my head ever since. And I quote, "The most any Christian can expect of her or himself is to take hold of the near edge of some grave concern, and at some risk to self, lift." Today, it's my privilege and pleasure to introduce you to Andrea Shaw, a beloved friend and physician who doesn't hesitate to take hold of the near edge, and in many cases, the far edge as well, and lifts and lifts and lifts. Andrea is director of the Refugee Health team at Upstate Medical Center, Syracuse, New York, where she is professionally committed to each patient being an informed patient. Andy is from Syracuse, New York, which is a sanctuary city. She completed her undergraduate Bachelor's of Science from Cornell University, a medical degree from Upstate in 2009, then completed internal medicine and pediatric training at Duke University in 2013. She worked at UCLA in primary care for a few years before returning to Syracuse to work in refugee medicine. She has over a decade of experience engaging in global health work in East Africa. In her current role at Upstate, she directs primary care services for refugee families. And at Upstate, she works with the Global Health Site in Kisumu, Kenya, for the Institute for Global Health and Translational Sciences. Andy and her husband, Professor Jok of Syracuse University, have 3 beautiful children, ages 7, 5, and now 4. In this month celebrating women, we are honored to have you, Andy, tell us about your practice of medicine. And I turn it over to you. Welcome, welcome.
Barbara, thank you so much for such a nice introduction. I'm really excited to be here with all of you. And I could talk all night about refugee health. So I am going to do my best to try to keep this to the 25 minutes or so that we have time for discussion and questions that may come up along the way, or questions that you guys want to bring forth to the group. So I'm going to share the screen. You see one slide or two, Barbara?
I think one side. Mhm.
Perfect. Okay, great. All right, so I'm going to spend the next half hour talking to you about refugee health. And in order to do that, I need to start at sort of the global picture that we're all a part of. And then I'll bring you down to where we are in Syracuse and what we do in Syracuse in an attempt to address the health disparities that refugees face and improve health equity for refugees. So we'll start by reflecting on the global process that brings refugees to the United States, review the challenges and successes that they face amidst resettlement, and understand our program a little bit more in a granular sense in Syracuse. So we'll start with the definition of a refugee. So the United Nations has really defined a refugee as anyone who is fleeing persecution. So whether that persecution is due to war, famine, environmental stress, sexual orientation persecution, political persecution, if you don't feel safe to be home and you flee home, you're considered a refugee. So that's broadly a social definition in my mind, because when it comes down to the numbers that are actually counted as refugees, those numbers are I think, a large understatement. This is one of the reports that the UN put out just prior to 2022, showing that their estimations of displaced people around the globe is 100 million people. Within that 100 million people in the year of 2022 that were forced to flee home, about 2/3 of them remained within their own home country borders. So they're referred to as internally displaced people. They don't count them as refugees. Yes, they're fleeing persecution, but they remain within UN protection and they're counted within their own country. So an internally displaced person. 1/3 of those in that 100 million number are counted as refugees and asylum seekers. And those refugees and asylum seekers have crossed a border and are requesting legal status and a safe pathway to legal status in another country. Asylum seekers are taking a risk to do it on their own based on the country that they've landed in. For example, you're in Democratic Republic of Congo, you flee across the border to Tanzania, you stay there and request asylum from the Tanzanian government, you're an asylum seeker in the country of Tanzania. If you live in a refugee camp in Tanzania and you're counted as a refugee, you're not an internally displaced person because you moved across the border from Congo into Tanzania, but you're living in a camp, you've settled and basically told the UN, I have nothing left to offer, and I'm going to request refugee status. At that point, you give up all rights to decide where you're going to go, when you're going to go, and how you're going to go. The UN will claim support for your safety, which means that you'll get the bare minimum of whatever that country offers. So someone in a Tanzanian refugee camp is going to live like the poverty level in Tanzania. You'll be given a plot of land. You may not have electricity or running water. There'll be a borehole. There will be basic access to education parallel to what is taught in that country. So Swahili will be the primary language of your education, and a basic health infrastructure that's offered to everybody else in that country for the public. So that's what you're offered. And the average family, before they get resettled, spends 10 to 20 years in that state with no idea which year they're going to leave or which country of the 30 countries that opens their doors to resettled refugees they'll land. So many people in the United States will say, well, why didn't that refugee spend time learning English in the camp all those years? They had 15 years in a camp to learn English before coming to the United States. But they didn't know if they were going to land in Norway, in Germany, in the United States, and the Tanzanian government doesn't support English as the primary language in their schools. So you have to understand how vulnerable these refugees really are. And that's where the next numbers will make a little bit more sense. to understand why this is a very undesirable path to get yourself to a better life. So the vast majority of people who flee persecution will use everything that they have to make their life better in the next step. Think about your own family right now. If there was a horrible war that broke out and threatened your life in Southern California, where would you go next? If you couldn't remain in the United States, where would you go next? Most of you are probably thinking about a country where you have family members, maybe a country that speaks your language, maybe a country that you could afford to live in. Later, you'll think about the legal steps, a country that might accept me as a citizen, like I could apply as an asylum seeker and request a legal path to citizenship. That's what anybody fleeing persecution does. This is a natural process of what anybody fleeing a war would try to do. Accepting life in a refugee status in a refugee camp really gives you no control over those next steps. And you're saying safety is my only option, and I have no means, no transferable skills, no funds to put me anywhere else other than here. So it's a pretty desperate situation to be in. And at some point, one of 30 countries might open their door and take your family for resettlement. So let's look at some of the numbers of refugees and where they come from. So over the last decade, you see the number of counted refugees went from about 10 million up to about 20 million. We're close to 30 million now. We're close to mid-20s. And again, these are people who are just registered as refugees. So these are not people who are crossing a border and trying to start that next life with their bank account spent or with their savings in their back pocket. These are not people who have put themselves on a boat and are trying to cross the Mediterranean into Europe. Those people are not counted in these numbers. These are only people that are counted by the United Nations. So you've registered yourself, you've made your case, you've said your family is being persecuted, it's not safe to be home, and this is why. And that's when you get counted on this graph. So you can see that the last decade has just taken off. The bulk of my patients come from, this yellow is sub-Saharan Africa, purple is Middle East, blue is Southeast Asia, East Asia and the Pacific is the tan color, and then a smaller number from Latin America and the Caribbean, and a smaller number in the red from Europe, largely from Eastern Europe, Ukrainian refugees. So the reason for the numbers likely to be lower from Latin America is not because there's less distress or less persecution, but there's been other paths that people have tried that they thought would help move their families along quicker. So if they were able to cross a border and either seek asylum or way to find a path without a legal status to still support their family, that was a quicker end than waiting in what feels like a little bit of a purgatory situation to be in a refugee camp and not know where you're going to go when. So in 2021, the total number was 27 million registered refugees. The number that returned home that year means that almost 500,000, almost 500,000 people went back home. Home is war. Home is famine. Home persecuted you. But that gives you a sense of what the state of life is in a refugee camp and how hopelessness wears on you over time. And people look at their life in a refugee camp and don't see future for their kids and say, I'd rather risk going home to war than waiting for somebody to resettle me. In the year of 2021, our government was at the end of a regime that was not refugee friendly. And we settled the fewest refugees we've ever taken, which was 13,700 in the year of 2021, just as Trump's administration finished. Globally, across the globe, across 30 industrialized countries that take refugees, there were only 57,000 people resettled. That's less than 1% of those people requesting resettlement actually get resettled. Those odds are terrible. Most of us wouldn't play that future dice for our family if given the option. So the US took about a quarter of those that were resettled globally. Canada, Australia, Germany tend to be big countries that follow. And US and Canada are usually amongst the higher folks that resettle. But we talk about them being countries that accept a lot of refugees, but really the bulk of refugee support falls on the countries that are next to those countries in conflict. So the countries that host the most refugees are Jordan, Uganda, countries that are right next to where the conflict is happening. So these conflicts go on for years and years, which leads to many people in a chronic state of stress. And then I'm going to talk about a couple other programs that have evolved since the last administration. So as our presidency changed, there was a change in attitude towards people coming to the United States and an attempt to create a legal pathway for people, knowing that that is the safest way to keep them healthy and productive and join this population and join the melting pot that we are in America. In 2021 to 2022, the Biden administration put in the APA program, which overnight doubled our resettlement numbers in that year. So in 2022, we were geared up to take about 100,000 refugees into the United States. And overnight, we transferred an additional 85,000 to Army bases across the United States and then to resettlement cities. So resettlement cities tend to be places like Syracuse, where cost of living is relatively inexpensive and jobs access may be good due to certain industries and benefits that they have. We'll talk more about that in a minute. In 2022, the program that started in April was the U4U program, which really allowed for an open end to Ukrainian refugees who would come. So with each of these programs I'm talking about, the supports get less and less, but the legal pathway is there and the access to medical insurance is there. So from my window of the world, I feel that people are safer in these paths and have access to medical care, whereas otherwise they would have been forced to live as asylum seekers. Asylum seekers are refugees who have fled persecution. They've landed into this country, and then they have to go through their own independent legal process to request the right to stay here. So an asylum seeker, usually an average of 1 in 5 of those cases, will be accepted by the government. So if that's your odds of being accepted once you're here and you've safely touched down in this country, you and your family may take the roll of the dice to say, I'd rather be among the 80% who don't pay those legal fees and risk getting deported. I may just stay here and work. That you're an asylum seeker, but you're not processing your case through the government. So that's how social refugees land in our lap. These programs are in place so that people have a pathway to green card and citizenship over time. The United for Ukraine program depends on sponsorship. That sponsorship could be a church, it could be a family member. Somebody has to say, I am here to support some of the assimilation process for this family. Many of the resettlement agencies have taken on the supports to help get them access to food stamps and safe housing and Medicaid when those families that are supporting them don't always know those hoops to jump through. And then most recently, the Cuban Haitian program has reopened. It was last up and functioning in 2015. And now that has expanded again to allow family members who make it to US soil, who have a family sponsorship, to also gain a legal pathway to citizenship. There's most recent talk of the Nicaraguan program reopening as well. I just don't have the details on that one. But those programs involve family sponsorship. They don't involve that purgatory step that the standard refugee path has left you in a refugee camp or unknown refugee status. So this is how refugees make it to the United States. I put this graph up just to show you that really we had a surge from Southeast Asia after the Vietnam War. Refugee resettlement really bore out of the need for people to have a safe haven after World War II. So it was really in the 50s when globally the refugee resettlement process took off. The numbers in the United States ebb and flow. Usually 10 years after a crisis, you see a wave of people coming. But that being said, I can't really map out history in these graphs because it's very political. So right after 9/11, you see this acute drop in all refugee resettlement that happened. And then there's additional changes based on presidential determination. So every 4 years, we have a little bit of a climate shift on how we accept refugees. So these bars are just here to show you that we're never usually above 100,000 a year. And that's how we formally resettle refugees. And that's how refugees formally come to Syracuse and integrate into our community here. And I think next slide. So this is showing across the United States where refugees coming from. Democratic Republic of Congo is very strong, largely because the vetting process that the United States puts people through involves 2 years of very intense screening. So very intense FBI screening, every fingerprint, every email address, every Facebook like, every address, every phone number you've had and your extended family all gets scrutinized. And if it flags positive for anyone, your family may either be blocked or an individual family member may be blocked from coming. So it's a stressful process for a lot of people. There's many from the Middle East that don't make it through this process, but Democratic Republic of Congo has been a country that historically has not been in political conflict with the United States, and many people have been accepted to come. There's very political decisions and a stroke of a pen from the executive committee and Congress that say we will accept X number from Congo this year, 0 from South Sudan, 3,000 from Burma. So they go through and they make their determinations with political decisions in mind. And there's more than enough people asking to come that they seem to be able to do this. Where do they go? California is always in top 3 or 4 state every year. I think most recently it was number 3. So Texas, California, and New York in the most recent years were the top 3 as far as numbers of refugees resettling to those sites. And many times they're blue states and states that have good social programs. Even though there was historically a lot of people resettling to Georgia or North Carolina, I would have patients move up to New York from Georgia and North Carolina because states without Medicaid expansion would expire, the refugees' Medicaid would expire after 9 months. So unless you had a job that allowed you employer-based healthcare, by 9 months in the United States, you'd lose access to healthcare for your family, which was stressful for people. So they would many times move to New York or Michigan, and California as well. So why Syracuse? It's a welcoming city, a long history of resettling immigrants to this area. The cost of living is reasonable. There's a long history of resettlement agency support, and we have a pretty diverse population here. 13% of the city is foreign born, with a higher density in certain parts of our city where people resettle. Almost 20% speak a language other than English in their home, and we have had just thousands of people come from all over the globe. So the flavors of Syracuse are sort of blended, and you can walk up the street on the north side and you can get anything from around the world in just a walk. So I know you can get anything from around the world across LA, but you're going to be in traffic for a little longer to get there, to get all these pieces of things. So anybody who wants to come to Syracuse, you're welcome. Just send me a message. So this is just an example of, having the political will in your city to embrace this. I think is an important message, both for tolerance, cultural humility, and just the human side that this takes as well, because this is really important. When you bring a highly diverse refugee population into an impoverished city, you naturally have interfaces where there's going to be stress, whether it's stress between African Americans who live here and African immigrant kids in school. These are all interfaces that we see, but when you have leadership like our mayor, Ben Walsh, who's been very welcoming to refugees and supportive of early businesses, I think this is really important. So he just recognizes that we've stemmed population loss, and that's brought a level of diversity and culture that's unmatched to small cities our size otherwise. So he's been very supportive of refugees. We see it as a win-win overall. Refugees are by definition survivors. They will fill low-wage, low-skilled jobs that don't require language proficiency. 40% of my adults never had an opportunity to go to school in their home country. They may speak 7 languages, but they can't read or write in one of them. That makes it difficult to really move beyond some of these low-skill jobs, but they're determined and they find ways, and the resilience is incredible. Many of them are entrepreneurs. They bring a lot of the entrepreneurship to areas, creating jobs and potential expansion of markets. Many people will say, oh, but they're just on welfare. And so it does take them about 15 years to surpass the median household income, but it's really their children. They came here for their kids. They wanted a better life for their kids. No parent is going to wait out 15 to 20 years in a refugee camp if they weren't there for the next generation. They sacrificed and risked things to keep their kids safe and try to get them on a better path. So it's usually the kids that graduate high school that are able to give back to their parents in the next generation that pull these families out of poverty. But that culture and that social fabric, it's not always perfect, but I think we learn from them, they learn from us, and it's really a blend that makes America the melting pot we are. Many people will say, oh, they're just here to try to get on disability and avoid this citizenship exam. It's not the case at all. We've looked at the data. The number that are requesting disability is no more than that local population, despite the fact that they've been through horrific trauma and war. You would think more would be asking for disability, but they really do want to work and try to pull their families ahead. Our city school district constantly has the top performers and valedictorians that are refugees who are making it through and doing really well. So I could talk all day, and I have way more slides than I can present. So I'm going to try to just move through a couple topics real quick in the next 5 minutes. This graph can be really used when you're thinking about disparities for any minority population. So any place you are, there will be some sort of system set up for the non-minority or the majority, which is the green bar. And if our top bar for everybody is that everybody gets the best quality of care and everyone has the right to health, we want this bar for everybody at the top. But no matter what vulnerable population you're taking care of in the minority, there will be some level of difference. We fight to eliminate this difference. And we fight to do that by addressing the factors related to our patients, addressing provider bias and issues related to providers and how they support vulnerable populations, and then systems that have structural violence in place and policies that really impact people's health. When it comes to patients and providers, a lot of it is about cultural humility. And I can sum it up in this great quote from a nurse theorist, Jean Watson. To care for someone, I must know who I am. To care for someone, I must know who the other is. And to care for someone, I must be able to bridge that gap between myself and the other. This sums up refugee care on a lot of levels. If I don't recognize my power imbalance or how I'm perceived by the patient or the bias that I might bring to the table, then I'm not going to be able to bridge that gap. If I don't take the time to understand where this person is from and where they've been, I'm not going to be able to meet them at their level and make sure that we understand why we're here and what our goals are and how we make that care plan together. So that's what bridging that gap is about. And we used to talk about it like cultural competence, like you wanted to know a little bit about everybody's full story and the history. You'll never know all of the backgrounds. We have 50 languages spoken in our clinic. I'm never going to know everybody's historical story from every conflict, every country. But that brings you down to the patient in front of you and how to present yourself in a culturally humble way. Just simply says, I'm here and open to listening to your story, because just because somebody from your country experienced this didn't mean that this person experienced it that way. So being open to listening to the patient in front of you, recognizing the biases on both sides and how to listen and bridge that gap is really important. Refugees by definition have faced persecution and don't feel empowered to speak up in a lot of these cases, recognizing how those layers of oppression compound and really affect a person's psyche and their ability to react and advocate for themselves. Recognizing the tenet of trauma-informed care. When you know that somebody has been through horrific trauma, you're not there to ask directly about the trauma and re-traumatize them. You recognize the themes related to the trauma and you create a safe space so that people feel comfortable talking to you. And being aware of what their symptoms might be or what their stressors might be is how you better serve them. So this is just more on the side of care. And this is more on the details of the diseases and the things that we address in refugee care. So you'd think we take this global population from around the world, many coming from equatorial sites. So when I get to teach refugee medicine to residents and medical students, we get very excited about tropical endemic diseases, parasites from around the world, screening for tuberculosis and hepatitis B. All of that is well and good. That's really the top of our pyramid. The bulk of what exists sort of under that iceberg or the lower layers of the pyramid is chronic disease. People and populations who have been exposed to chronic stress over time will have a higher prevalence of chronic disease than the average American. So somebody who has been through war and chronic levels of high cortisol levels in their body is at a higher risk for high blood pressure, heart disease, and diabetes than the average American. We don't see the typical presentation of somebody who's presented with overweight, insulin resistance, and diabetes. We just see frank diabetes in a normal sized person. So this is really important to be aware of because refugees don't come from systems where they're familiar with health screenings or really familiar with chronic disease management. So this is the bulk of what we deal with. And then lastly, the bottom of the pyramid, sort of the hidden story under everybody is that they've all fled trauma, but everybody reacts to that differently. And so you just have to be open to how it may or may not have manifested in your patient and be willing to address mental health concerns as they arise, if and when they arise. So lastly, I'm going to touch on just a few policies because I think some of these are just learning points. Sometimes people are not aware that some of these things exist. And these are things that I feel like is really where social advocacy sort of drives policy change. And as much as we say the world is data-driven, sometimes it's also anecdotal-driven because people who make the policies don't always realize the impact that they have on everybody else in the system. So when I think about refugee health, up until 2009, HIV was a diagnosis that would exclude you from coming to the United States. So if you were sitting in a refugee camp and you had HIV before 2009, you never had an option to resettle to the United States. That was just one of 30 countries, but how would a refugee know the different policies to different places? So these types of policies, number one, don't make any medical sense. From 2002 onward, the whole world had access to antiretroviral therapy thanks to the Global Fund to fight HIV, tuberculosis, and malaria. You could find antiretroviral therapy at every rural corner of this globe by the mid-2000s. So for us to exclude people who had HIV was highly discriminatory and only created fear across the globe for refugees. To this day, I have patients in 2022 who come with undisclosed HIV because they were afraid that if they told somebody in the camp, they would be excluded from resettling, which is horrific in this day and age when you can control this as a chronic disease. So thankfully, it was a lot of social advocacy in those years that overturned that in 2009, but the damage that was there from those policies still exists and affects patients. Second, the federal government supports agencies to provide 3 months of case management. I want everybody on this presentation to imagine yourself in a foreign country that you've never been. I won't pick one because you guys may have been in some of these countries, but I've never been to Bhutan. I'll place myself in Bhutan. If somebody took me from the United States and put me in Bhutan and expected within 3 months that I would be able to feed myself, support my family, make sure my kids would stay through school, access healthcare, keep myself safe, after 3 months of support, I couldn't do it. But that's what our resettlement program supports. There's a lot of creative funding and goodwill that follows people after that, but we all know that it takes at least a decade for people to really work through a lot of the challenges of the assimilation process, and it's no surprise. Another surprising fact is the arrival plane ticket. So you're a refugee, you've been sitting in a refugee camp for 15 years, you got your family a ticket out of there, and great, everybody gets on a plane and lands in a foreign country that is now going to accept them for resettlement. Within a few months of arrival, you get a bill for that plane ticket for your entire family. You may have a family of 10. you just got a $10,000 bill in the mail that's going to follow you with no interest, thankfully, but it's going to follow you. So in a few years' time, when you're really sick of paying rent and you're trying to buy or get a loan to buy a house, this $10,000 bill is blocking you from doing that. And I can tell you that even though refugees do want to save and want to pay off bills, every refugee that comes to this country has a family member overseas that needs something more than they do. Once they get here and they can eat and they have a safe roof over their head, many of them, the first thing they want to do with the first bills they get is send it to people back home or in the refugee camp who are worse off than they are. So it takes time for them to pay these off. I feel this is a little bit unjust that we offer a safe haven and offer resettlement, even through an IOM and United Nations supported system. These are things that impact people's health because this debt becomes a health concern. These are the social determinants of health. Lastly, in order to gain citizenship in this country and formal status as a US citizen, after 5 years being here, you have to pass a citizenship exam. It's a civics exam that's done in English. The only way you can get around it is if your doctor fills a multiple page form outlining the disabilities that prevent you from learning English. And those disabilities do not exist like just because you never went to school, just because you never learned to read or write in your own language. Those are not disabilities that prevent you from learning English. So even though those first 5 years of assimilation are the hardest for you to figure out how to get a job, maintain a job, support your family, keep people running, you also have to learn English during that time and take classes specifically to study civics. These things, I think, are examples of structural violence when you have policies in place that impact people's health and really need to be looked at. Because I think the policies were put in place for a reason, and we can talk about why. We could discuss why one might put such policies in place. But I do feel that refugees, given the state that they come in, given the process that they take to get here, should have some balance of compensation for this. We won't talk about how difficult it is to live at the poverty level and renew your benefits every year and address a lot of the uncertainty that it takes to live month to month at the poverty level, which is really the first decade of life for most refugees in America. All right. I want to leave time for questions, and I've already gone over. So suffice it to say, our team here in Syracuse is really built up of a highly diverse clinic that brings supports together where we've hired people who speak the languages, healthcare providers who speak the languages, and we partner very closely with the community because really healthcare is this small little gray feet on this human and how to support population health. Most of someone's health is going to be influenced by their behaviors, their environment, and their socioeconomic factors, and not just the healthcare system that they interface with. So I will pull these slides up if we have questions related to it, but I think my last point is simply to say, refugee health navigators are my community health workers. Community health workers are a population that exists around the world, and the United States has not done enough to really support that population community level of support. And I look over time to continue to make these people sustainable in the system. Right now, we have multiple grants that help to support them, but they are really former refugees with an interest in health. Right now, we have 12 of them that speak over 25 languages. They are hired by the resettlement agencies, and they work very closely with these families in the first year of resettlement because 3 months just isn't enough to figure out life here. So this links somebody who's culturally and linguistically aligned with the family for a minimum of a year. And we've proven that we can save costs, keep people out of the emergency room, keep people healthier. So far, the people who are listening to that is actually the health insurance companies, because they're the ones helping us with some of the grants to fund these positions. But it would be really nice if this was a national program at some point that really provided standard care and standard supports in place so that we had these folks there to help refugee populations be healthy and safely assimilate into the communities that they're in. All right. So in summary, Syracuse is a global village. Diversity is certainly our strength. We appreciate the struggle that refugees have fled and continue to face, but they certainly play an integral role in our melting pot. And our Center for International Health is just an example of how we focus our resources and try to align our resources to better support a highly diverse population that would otherwise be vulnerable, sort of lost in the system, if we just took an equality approach instead of an equity approach. I've got to leave time for questions. Sorry, I ran over, Barbara.
No problem. Andy, I would like to start by, I may have missed this, but how many such programs like yours exist in the United States right now?
So we get together every year at a national North American Refugee Health Providers Association, and we have strong representation from largely academic medical centers that partner with county health departments. So Minnesota is a big one, Denver, Michigan, Vermont, Providence, Arizona, Utah. There's a bunch of, and refugees do make it to most states. It's just that historically, certain cities are more refugee friendly than others. And cost of living is a big reason why certain people will settle certain places. Like in New York State, we settle 0 refugees in New York City, but across upstate New York and across the Thruway, Albany, Syracuse, Buffalo, Rochester, Binghamton, Utica are the sites that people go to.
Mm-hmm. Thank you so much, Andy. Let's open it up now for questions. You can either, let's see, there is one in the chat. Let's see what that one is. Please talk more about your sources of support and if grants always are being renewed and other resources. The question's from Nancy Mackey.
Yes, I wish grants could just be automatically renewed. That would be wonderful. But we do have, so I work in a university salaried position. So my academic role is in some ways protected in that space to actually provide the care. And refugees all have Medicaid insurance, and that's how our population is able to support that. But a lot of our more creative work that I think really helps address the health problems more than a doctor's visit, because in 20 to 30 minutes when you're working with a translator, I can only get to so much preventative health discussion. For a patient who's never experienced a dentist or who's never had a cancer screening before, talking about these topics is not effective one-on-one. But when I get grants that help us support the navigators to have community sessions, to facilitate support groups, to have focus groups, to discuss issues that overlap their cultural perception of health, as well as what's happening. I think mental health is the biggest one that comes up because we'll have people's cultures that lead them to believe that they're bewitched or that something has happened to them or it's their fault or the stigma is so real or it intersects with their religion in a negative way. We can't have those discussions in a clinic in a productive way. So the grants that we've gotten over the years, some of them have been from SUNY, which is our State University of New York, similar to like the UC system where we have some internal university grants. Some of them are federal grants from HRSA or Office of Refugee Resettlement, and others have been faith-based groups like the Cabrini Foundation and other smaller foundational grants. A lot of the work that we do operates on a relatively small budget. One of the most important things to me is that we are supporting the health navigators and we are supporting community members when they participate in focus groups or research and other things to really make sure that they're included at the table and that these grants aren't just going to materials and salaries.
Bill Craig, I see.
Introduce yourself.
Oh, Bill, you're muted. Bill, you're muted.
Would, but he's
Yeah, you're still muted. There you are, Bill.
Okay. Thank you. Tremendously informative and challenging presentation. For that 1 year sponsorship, could you give us just a concrete example, a story that would help us
That's exactly.
understand the effectiveness of that particular strategy?
Yeah. So you're referring to the 1 year support from a health navigator, correct?
Yes, a health navigator.
Yep. So I see, a family comes in, and in the first 90 days, their case manager has a checklist of everything that they need to do for them. They need to get them their house. They need to help them pay their rent. They need to get them their food stamps. They need to get them into school. They need to get them all these places. So all these firsts are sort of a honeymoon period, and they check all the boxes and then they walk away. And after that, you actually learn the health navigator, when they're by their side, they not only translate things because they're not there for word translation, but they take it to the next step and they help bridge that gap. They say, back home, you used to go here for this health service, but here in this country, this is how we do it. And we go to a primary or family doctor for things before they become emergencies. We don't just go to the doctor when we feel like we're dying. Or we might be asked to take medicines even when we feel well to treat latent tuberculosis, even though you don't have active tuberculosis. We don't want it to ever become active. And this is why they're recommending the treatment to you. Or it's really important to be followed during your pregnancy, even though back home, you never delivered in a hospital, you never had an ultrasound during a pregnancy, you never sought treatment until you were delivering a baby. These are the reasons why we do it in this country, to try to keep you healthy during this time and prevent bad outcomes. So they really bridge what it was like back home and what it's like here and why some of those things are different. It's not to say that one system's perfect and the other, but that degree of cultural translation, I feel like really helps people buy into certain things, whereas otherwise their tendency is to sort of fear and withdraw and run away from certain things. They may ignore symptoms for a while because they don't really understand how to access care or where to go. Waiting in the emergency room wasn't effective. So.
Very helpful, thank you.
I have a question.
Jim, go ahead.
We, over the last couple of years, has become particularly concerned about Ukrainian families coming. And I wonder if you have a story you might tell about a family or families from Ukraine and how they are doing moving to Syracuse.
Yes, so we have had many families coming from Ukraine, and I can certainly say that the wave of Afghans who came in 2021 to 2022, and then in this past year, the Ukrainians who have come, feels like a humanitarian crisis as opposed to refugee resettlement, which refugee resettlement is a very slow, drawn out process. And this situation of Ukrainians crossing the border with a piece of paper that has a sponsor on it and connecting with a community has been really trying to support them from a humanitarian level, but also recognizing that the level of trauma and distress in these populations is through the roof. So when men have made it out and their counterparts are back at fighting, the survivor guilt is huge. We've seen a lot of moms with young children who have their male counterparts in the family back home and fighting. So I find that the distress for this population is really hard to tap into or really hard to support because I can't fix the primary trauma. Mental health providers are well trained to help people cope with some of these things, but culturally, I don't know that people were ready to meet with those providers or meet that interface with our mental health system. Our mental health system, in order to be successful for patients, really takes a lot of proactive effort by the patient. The patient has to recognize that they want to talk to somebody about these stressors. And culturally, I found that the Ukrainians by nature are very stoic. They don't want to relay that things are falling apart inside. You tap into some of it in a medical visit and you're all crying together. And it's really hard to see these families really torn apart without an end. You know, a war that everybody thought would end months ago has no sight in end on the horizon. So I think they're appreciative of a safe haven, but not a single family wants to be here. They all want to go back now.
Thank you. Barbara Dosker?
Yeah, speaking of refugee, is it more difficult for a family to get relocated than a single person?
Is it more, the question Barbara asked, is it easier for a family or a single person to get resettled?
Is it more difficult for a family to get relocated than a single person? Or do you find single persons in refugee camps?
We get lots of single people from refugee camps, but I think the nature of people being stuck in refugee camps for 10 to 15 years, sometimes they form families. And I have many generations of kids who only knew a refugee camp because families, you know, people made their lives together or brought fractured families together with a mom and dad that then had later children. So many times we're resettling refugee families, but I'd say we get just as many single people coming too. So I think, you know, the political decisions that go into why certain people come and others don't is not that clear, but you can see some of the path of privilege even through refugees. For example, the Somalis who have come since the conflict in the 80s, the first wave of Somalis that came were the Somali, who were those who were educated and who had more resources. The second waves that came were the Somali Bantu, who were not literate, the farmers, the second-class citizens. And so we see this coming from certain areas where the people who sort of make it out first had more resources along the way. So we all know that paths are not fair. Even political decisions are seemingly unfair when they change from year to year and policies change very quickly. So I think we all scratch our heads with why certain people come when they do. But sometimes I just step back and I stay in my lane and I just support who arrives because I can't influence those bigger decisions.
Yeah. Thank you, Andy. I'm going to call on Larry, but if I could just ask all of you who are not speaking, if you could be sure that you are on mute, because sometimes we hear other conversations that are taking place, and it's difficult to hear both the questioner and also Andy's response. So just be mindful of muting yourself unless you are asking a question. Larry, why don't you go ahead?
Yeah, the healthcare navigator. I assume they must be able to speak the language of the refugee. How difficult has it been for you to find those people?
So these people are often people who are trained in some sort of health capacity in their home country. Many of them were community health workers in rural areas in those countries where refugees have come from. Those folks, even though they have training in health backgrounds, they don't have equally transferable skills here. Like yes, they get their English up, but for example, let's say they were a nurse back in Rwanda, and then they want to come here and be a nurse. They not only have to speak English, they have to get through our nursing programs and our certification programs, which many times takes a long time due to expense and time and challenges of resettlement. So I may have a Rwandese nurse who speaks English beautifully. She was a Rwandan nurse back home, but she doesn't have an equivalent job here. She's my perfect health navigator. So we do find a number of these people, and they do like the style of the work because a lot of it is really just boots on the ground, helping people when they need it. It's not necessarily a desk job, and they're compensated for their time to really help and advocate. The bridges of trust are almost instantaneous and real. When vulnerable refugees arrive and they see you have been here 5 years and you survived, we're at a point where like they hit a little honeymoon when they first get here, and then they're like, wow, America was not what we thought it was. And this is a lot harder. And within those first 2 years, and when they hit low points of like, I don't know how to figure out whether this is a bill in the mail or how to keep the lights on in my house or how to pay the heating bill, you know, this person has gotten through all of that and struggled with all of those structural steps along the way. So they help them learn the system a lot quicker. So I think this layer of people in our community is invaluable, and it needs to be supported both from a state and from a community level. But yeah, we find them because Syracuse has brought a lot of refugees here.
If I could just jump in here for a moment and just tell a personal experience. Before Andy and her husband Joke were married, he was our housemate, and because he had his doctorate in public health and medical anthropology, even though he was full-time professor at Loyola Marymount at the time, I remember his phone ringing day and night, and so many weekends he was gone to troubleshoot for South Sudanese refugees who had run into just some of these enormous roadblocks to resettlement. And so I must say I was a firsthand witness as to someone who was on call 24/7 for the refugee community.
And I don't think he was ever paid as a health navigator, or as a navigator, like even like life navigation. I feel like we just need to do better in those first year or two to help these families really embed their roots safely.
Right. Well, if there are no more questions, we have reached the 5 o'clock point. But Andy, I just want to thank you so much for introducing us to layers and layers of complexity in the kind of work you do and what faces these people who are new immigrants to the United States. I know I learned a lot that I had no idea about, especially after 1 year that they need to pay the transportation costs of their arrival with their family. That just, I'd never heard this before. So thank you so much for enlightening us on a subject that is not going to decrease, not in the world that we see right now. And we're very grateful to you for this time. And yeah, I see some hands clapping. I do want to give a reminder for next week. It will be Kathleen Burns Albrechtsen, and I think we're familiar with the Burns name on this campus. She is a lawyer and a partner of Albrechtsen and Shoemate Law Office. And Kathy is going to share with us the latest development in organizing and planning legal affairs, both to make it simplified, efficient, and wealth conservation. And so we'll be so glad to welcome her next week to our convocation. And this is the daughter-in-law of our own Karen Burns. So please join us next week. And Andy, wishing you well, and you go kiss those 3 children good night. For me too. Thank you so much.
Thank you.
Bye-bye, dear. Thank you, Esther.